Hi. Uh, Hello, good morning, good afternoon, good evening, everyone. Welcome to another Tuesday VMR. I'm very excited to be co-discussing with Ravi today. Always admire and appreciate Ravi for always being there to support like junior learners or faculty like us to discuss and learn. Also, really excited that Masa will be presenting a case. I'll pass the mic to Masa to say hi. Uh,
Hey everyone, I'm Masa. I'm a Syrian IMG from the United Arab Emirates. And today I'm sharing a case that Alec actually shared with me, which is one of our wonderful Academy members. So, Alec, if you're watching, I just want to say thank you. I hope your back is okay from carrying VMR on your shoulders for the past few weeks. And yeah, I'm excited to share this with you.
Yeah, and thank you, Alec, for being behind the scene. And also, thank you for Salsan doing teaching point and Menahil doing scribing, who make this session possible. Um, and then Ravi, do you want to say anything before we start?
Oh, sure. Happy Tuesday, everybody. Very excited to be here. I texted, I think, in the middle of the week to Mengyu that was like, hey, we haven't discussed in a long time, and that'd be great to sort of do this bi-directional thing, coast to coast, right? I'm on the East Coast, you're on the West Coast. And both of us are APDs, PDs, so we're in that kind of stressful time. How's your role going? How's the selection? We're coming down to March, exciting time for everybody. Match time is around the corner, so we're very excited to see who matches to whichever program, and especially all of our wonderful Academy members. So best of luck to everybody out there. How's things with you, Mengyu?
Oh yeah, things were busy in the past couple of months, but finally taking a break now and back to more time with, you know, dedicating to learning and teaching like medicine. So yeah.
Excellent, excellent. And we have a case, and thanks to Alec for this case as well, and also for Masa for presenting it. So we'll start off with the first aliquot. Over to you, Masa.
Okay, so we have an 81-year-old man that presented after a fall. Per EMS, the patient was at a bank talking to the teller this morning when he reportedly began slurring his words and he became confused. He subsequently fell backwards and hit his head. It wasn't clear if he lost consciousness. Per bystanders, he had a seizure-like activity, but for an unclear duration. He remained altered upon EMS arrival, and a C collar was placed, and he was transferred to the hospital. He slowly improved, and on review of systems, he did not report preceding chest pain, shortness of breath, headache, dizziness, or any other symptoms. He doesn't remember exactly what happened. He just remembers speaking to the teller and then waking up in the hospital. And this is my first quote.
Uh Yeah, what a great interesting start, Masa. So, at first when I hear the word fall, I was thinking, oh, there could be neural internal and external reasons for the person to fall. But then as the story evolves, it seems like the chief complaint or the main problem to solve has become a loss of consciousness. And for that, we have the 6S mnemonic to kind of help us differentiate. One, most common being, I'll go to that later actually. But then there's also some collateral information around like slurred speech or um, uh, and yeah, but I think that is really just around the central problem, which is the loss of consciousness, and could be secondary to, although we think of stroke or related uh, um, problems, but I think really clarifying how the patient had the loss of consciousness. For that, we have the 6S. The major ones are seizure versus syncope, but there's also like sugar, substance, um, stroke, or I think there's sleep problems. So I think those are some rapid tests that we can do. Or if I think now that the patient is awake, And the best way to actually differentiate seizure and syncope is to know if there's post-ictal confusion. If there's like with seizure, there should be like confusion for a more prolonged time after a seizure. But I think sounds like the history here is not very clear in terms of how long the patient was down. If we could get that information, it would be very helpful. If the patient was only down for less than a minute, like a few seconds, that would be more supportive of a syncope episode. And then rapid things you can do in the ER is to like check glucose and scan, asking about any substance use, and but I think those are kind of less likely at this point. But yeah, I want to pass the mic to Ravi.
Oh, Mengyu, that was such a splendid start to this case. And this is a case you've probably seen many times in the emergency room. Once those of you that are interns, attendings, you see many of these cases that come in and usually are put into this observation status because we observe them because we haven't made the diagnosis. The diagnosis will be through observation or maybe by getting the history and seeing like, has the patient been maybe not eating, drinking for a few days? So the sugar, the volume, Mengyu had mentioned one of the 6S's. And by the way, that 6S is very powerful. And we did make a slide about it. So early on in VMR, this was put together. And then one day I just put it on a slide. And I think it really does have real world implications when you're there at the bedside. Pan recognition, 6S, if you get the diagnosis, hypoglycemia, you don't really have to do much more work. You have the cause of it. Then you start management reasoning and start working on the management of this patient. But here, this is a really complex sequence of events, right? So first he's at a bank and he begins to slur the speech and so gets confused. I hope they didn't tell him at the bank some awful news like his bank account got wiped out or something like that. That could be very shocking. So that could actually cause a vasovagal episode. And syncope and seizures, I mean, they can happen hand in hand, because if you think about what is the definition of syncope, it's a momentary lapse of circulational perfusion to the brain where you can actually suffer seizures. So it could be a cause of a pseudo seizure. Or in fact, did he have an actual neurological event like a seizure or a stroke, which can actually trigger a seizure because he's slurring his words, getting confused, and then falling? If you kind of take fall by itself, is this true syncope or did he actually have a fall? I like this whole trying to figure out why somebody falls. We've done on CPS, there's been cases like trying to figure out the physiologic dysfunction. In an 81-year-old, there could be the autonomic dysfunction, which could be causing this, right? So it does take quite a lot for the body to stay straight when you're trying to resist gravity. So there's various factors which could be cardiac, neurogenic, and so on, and then stuff in the neurovascular system, so the volume, blood, and so on. Then you also have to look at the environmental features. So is there something like Mengyu has mentioned, one of the 6S is substances, right? Could there also be something in the environment? You walk and then you have a rug and you trip and things like that. Bad stairs, lighting. With our senior patients, it's vital to eliminate the excess around the environment because this triggers falls, right? Somebody gets up at night and there's lack of lighting, there's shoes in the way and things like that, they can fall. But how about the intrinsic features? So intrinsic features could be anything like the syncope that Mengyu had mentioned. They could be also neurological issues, musculoskeletal issues, performance issues, and there are a few other things that I'm not remembering, but it could be an external issue, it could be an intrinsic issue, but I think here the key is that it's an intrinsic issue, and you will definitely see cases like that. I've seen many cases like this where we have to then work up, is it something that is life-threatening, like an arrhythmia, like a cardiac process, like a neurological process? So really great case, and I think there's a lots to learn for everybody that's here, and we'll see how this all plays out. But anything else, Mengyu? I said a lot, but this case is very rich, and I think definitely lots of learning here for everybody.
Yeah, I'm just reflecting more on like reading more about the HPI. It feels like now I'm thinking less about syncope because the slow in improvement seems to be quite remarkable. That may and the which make me more thinking about seizure. Also the fact that there's bystander who reported seizure. So I wonder if we could get more information around whether there's like they witnessed any seizure-like movements, like convulsive movements, limb shaking, especially if it's one unilateral or eye moving towards one side. Although I think it's usually hard to get those details, but I would clarify more. People think he had seizure, if EMS knows at all. But the slow in the improvement swing me a little bit away from syncope, unless there's like a consequence of an intracranial trauma that happens at the same time. But yeah, those are my.
That's, I think you're already onto something. So there is a sequence that's happening, and the last step was this falling back and hitting his head. So has he suffered some intracranial catastrophe? So could be anything from subdural hematoma. Usually won't manifest this quick, but maybe a concussion, significant trauma, intracranial hemorrhage. At 81 years of age, you tend to have more fragility in the vessels and the connective tissue. So any slight trauma could cause intracranial hemorrhage. So maybe what we're seeing at the end is due to the head trauma. But what was it that caused the issue at the beginning? So you see, if you take care and manage the trauma, you haven't really figured out what caused the fall or the syncope or the seizure initially. So there's sort of a twofold sequence that's happening here, which we'll kind of have to figure out. Back to you, Masa.
Okay, so for his past medical / past surgical history, he had a traumatic brain injury requiring craniotomy over 30 years ago. He possibly has seizures, although the patient wasn't sure about the diagnosis and he hadn't taken medication for years, but there were prior admissions for presumed seizures. He has type 2 diabetes, hypertension, hyperlipidemia, and coronary artery disease with a prior CABG. His medications, he's on insulin glargine once every evening, amlodipine, aspirin, atorvastatin, and metoprolol. His family did note that he took his long-acting insulin last night and hadn't eaten anything yet today, including prior to going to the bank. He does not regularly check his blood glucose. However, it's unclear if EMS checked his blood glucose at the scene. We do not have a point of care glucose. His family history is unremarkable. His social history, he does not smoke cigarettes. He does not drink alcohol or use any illicit substance use. And he's retired and he lives with his brother. For his vitals, his temperature was 36.8, blood pressure 169/90, his pulse is 81, his resp rate is 25, and SpO2 is 99% on room air. For his physical exam, on general appearance, he was awake in no acute distress. Initially, he was alert and oriented ×2 and a bit confused, but he slowly returned to be fully oriented and responsive without any specific intervention. And at his baseline, he's independent without any cognitive impairment. His HENT exam, he had a right occipital scalp hematoma with overlying superficial laceration and no obvious fractures. His pupils are equal and reactive, and the C collar is still in place. His cardiovascular exam showed a well-healed sternotomy scar, regular rate and rhythm, no murmurs. His pulmonary exam was all within normal limits. His abdominal exam was within normal limits. His neuro exam was also within normal limits, and his extremities, there were no obvious deformities or lower limb edema. And I will stop here.
Wonderful presentation, Masa. So there's at least two relevant sections here. What I'll do, I'll tackle the past medical history, meds and social history, and then Mengyu, if you want to tackle the vital signs and exam. So I think it's very important in such a case to really do sort of pause and look over the past medical history and see if there's anything there. So say if there was a cardiac history of ACS, that could have relevance. We would have to definitely entertain that in our prioritized list of differential diagnosis. But here, TBI 30 years ago, it's not recent, so I would kind of say that that likely has no relevance on this case today, unless it was like recently, maybe 2 weeks ago, a month ago, 2 months ago. So I kind of would put that to the on the back burner and then progress through to see what if there's anything else that I can sort of put my finger on. Possible seizures. That's kind of interesting. You either have seizures or not. So it wasn't clear, and it's not a issue of the person that's taking the history. What do you do with this information? It does kind of raise your antennas and maybe make the likelihood of seizures much, much higher in this. So plus with the craniotomy before, I would think this patient would have had seizures since then if the seizures were due to something like that. And also the key thing is to also look down at the med list and see, is the patient on anti-epileptic? Say the patient was on an anti-epileptic agent. Were they taking it? Were they able to get it? Were they able to, are they achieving a therapeutic level in the blood? Maybe not. So we would have to look at that. And anytime anybody comes in with any sort of med like Dilantin or anything like that, always get a level, because these drugs, Dilantin, digoxin, and so on, have a narrow therapeutic window, and it's very easy for them to get toxic. So always do consider that. A lot of medicine is anticipating issues, and that will be one that you would always think about. But getting back to the past medical history, diabetes is a big one, right? Remember, Mengyu said sugar, right? So sugar is key here, although I don't think it's the cause of it. But you know what? You have to strongly consider it. So in the labs, or if you're there at the bedside, ask your nurse, get a finger stick right at the get-go, and that way you can figure out, is it relevant or is it not? Say the sugar is low, correct it and see, but also cast a wide net to think about other causes. I've had conditions like adrenal insufficiency, patient with adrenal insufficiency, low glucose, they were falling. Patient was walking, syncopized, had COVID, one of my patients, and glucose was low, but only then later when he had normal glucose and continued to have syncope, adrenal insufficiency came into the picture, along with the labs and so on. But getting back to this case, coronary artery disease. This patient has had issues cardiac-wise, so this would trigger a number of certain testing. So that would be EKG and possible cardiac enzymes as well. And always remember, you'll be like, wait a minute, this patient doesn't have chest pain, but you always have to think about patients that are seniors, patients that have diabetes, patients that are post-op or on analgesics, they won't have chest pain. So diabetic patients have neuropathy, and so they may actually have what we call silent MIs. So at this point, he's not having chest pain, but I would get at least cardiac enzymes and EKG in this case as well. Looking at the medication again, what if he took too much glargine, hypoglycemia due to that? Amlodipine, metoprolol. So both of those, his blood pressure is actually high, not low. So say he came in with a very low blood pressure. What if he took too much metoprolol? His heart rate could be, I had a patient with metoprolol overdose and came in with a heart rate of 30. That could trigger passing out and syncope and so on. So definitely take a look at the medications. Aspirin could increase his tendency for intracranial bleeding. That could be something that would worry me. So definitely pause at the meds, comb through the meds and see what could be making things worse potentially, or could be causing this condition. Other than that, social history, what's interesting, non-alcoholic. So we always know alcoholism can cause cognitive decline, brain atrophy, more tendency to bleed when you have head trauma. Because of the support structures on the vessels is less, any sort of force to the head can cause shearing of the blood vessels and intracranial hemorrhage. Here though we don't have alcohol use disorder. But that pretty much is it. So with the past medical history meds, hypoglycemia comes in, coronary artery disease comes in, low blood pressure, bradycardia, unlikely, especially due to meds. But those two things I would check. Now I'll turn it over to Mengyu for the vitals and the exam.
Yeah, so looking at I love your discussion, Ravi. And then looking at the vitals and exam, I was, first starting with the vitals, I think the blood pressure being high, Although there could be conditions associated with like encephalopathy and high blood pressure, like PRES, that could be associated with seizure, which I discussed in a previous case. But here I kind of didn't pay too much attention to it because I think could be in the setting of this acute stress, pain from the trauma, and his baseline blood pressure also being high. We don't know how well it is controlled. So I didn't, I wasn't paying too much. It didn't trigger me too much. I wouldn't like weigh too much here yet, but I'll watch for the trend. In terms of, I think otherwise the neuro exam seems to be pretty unremarkable, besides other than mild still confusion, which could be residual confusion from the post-ictal state if it's or a seizure. But otherwise, there's no focal neurological deficit that make me jump to like a stroke. So I think that's partially reassuring, or like a big intracranial bleed. So yeah, I think the neuro exam is helpful here. Also, the notable scalp hematoma, I think, just further raise concern for, like, you would want to make sure there's no intracranial process going on, even though the neuro exam is reassuring now. So definitely a patient would need imaging and just overall thinking about the approach to like a possible seizure episode. Other than what we talk about, I think I usually also follow this same approach to altered mental status, where I use the MIST framework. I think of like a lot of metabolic causes like hyponatremia, hypercalcemia, hypoglycemia, or uremia, those, or hepatic process. I think all could cause seizure. And then, so basic labs would be very helpful. No clue for infection yet that we see, but see what the white count shows if there's any clue for that. And definitely getting imaging for such an elderly with brain with a scalp trauma, head trauma. And then lastly, toxin, we kind of talk about, we'll do like screen with alcohol, like a toxic screen. And I don't see any meds that will decrease the seizure threshold. So that's good. So those are the thoughts that came to mind. I think the MRI would be probably something needed, unless a CT scan is already revealing. Yeah, those are the thoughts right now.
Just a
Ravi.
few things that triggered Mengyu. Great discussion, I think. Yeah, the blood pressure. I love that. You kind of like, okay, the most common cause for this would be, look at the patient. They're going through trauma, pain, injury, and so on. Soft tissue injury that could be attributed to that. What's interesting, if somebody can type in the chat, we talked about intracranial, we talked about bradycardia, but the patient doesn't have bradycardia. So high blood pressure, bradycardia, and irregular breathing. Does anybody remember what that is? Great. Sosan got it. Quick Cushing reflex. Yeah, here we don't have bradycardia, we don't have irregular breathing, but that would be something of concern. How powerful is it? I don't know the likelihood ratio. If you have those, does it indicate intracranial hemorrhage? But it just kind of, for fun, brings something to mind, a potential jeopardy question. But yeah, there's nothing here that really is going to help us to make progress. No pivot point or inflection point to get to a diagnosis. I think all of the conditions that you discussed or mentioned, Mengyu, very valid at this point. The only thing that I would quickly do at the bedside is do orthostatic vital signs. In the guidelines for syncope, I think one of the first interventions to do, of course, glucose and getting the labs, get a orthostatic vital sign measurement. And in syncope, orthostasis is one of the causes, or major causes. There was an article years ago in the Journal of Emergency Medicine. They found about 20% of patients coming to the emergency room with syncope, they found to have orthostasis. So doing that vital sign measurement can be very helpful to decipher what's going on. But I'll send it back to you, Masa. Do you have orthostatic vital signs? If it's okay if you don't.
Unfortunately, I don't.
No problem.
Yeah, I'm really enjoying the breakdown so far. So for the next aliquot, we have the white blood cell count is 13.2. Neutrophils are 6.48. His hemoglobin was 13.6. MCV 93.8. Platelets 185. His metabolic panel was normal, including his glucose. His coagulation panel was normal. His urinalysis was normal. We got a chest x-ray, which didn't show any acute findings. And on the first CT head, without contrast, showed acute occipital scalp swelling without any underlying fractures. It showed trace left parietal convexity subdural hematoma, a focal right parietal convexity extraaxial hematoma, which was underlying the prior cranioplasty, and scattered left front and left occipitotemporal subarachnoid hemorrhage without any mass effect. And because of the concern for syncope and coronary artery disease, we got an EKG. I'm gonna share the EKG. One moment. Okay. Can you see my screen?
Yes, we can.
And this is the end of my first alquat. But I'm gonna tell you what like the EKG description
Sure.
was.
Sure. So what really stands out, anything Mengyu, just jump in, I guess. But what is really standing out is V1 to V through 3, the sort of upside down ST elevation that you would get. You're getting ST depression. So I wonder if there's something going on in the posterior. Then I would look at inferior leads 2, 3 AVF. 3 kind of looks like an ST elevation, but 2 is the opposite. Look at contiguous leads 1 AVL, you are getting ST depression, so that does increase the pretest probability maybe of this being significant. But if V1 to V3 with this configuration, I would be worried about a cardiac event.
Yeah, also like trying to think, I think, yeah, the EKG definitely jumps out with kind of diffuse ST depression, and even ST elevation in AVR which would make you think of, because AVR ST elevation AVR has a pretty narrow DDX, and the concern is like a diffuse stenosis, like a left like diffuse ischemia from like a very, very proximal ischemia, and the other is like a PE, or I'm trying to, yeah, like a left main proximal LAD, or triple vessel disease, like a diffuse ischemia. And although I'm surprised that the patient didn't report any chest pain, but maybe that is masked by the acute event, or maybe he couldn't report us, or maybe the diabetes kind of masked. Although, so that's one thought. And then like acute PE or like hypoxia could also cause like a similar picture. And yeah, those are. And then the other thought I had is like, since we have a pretty remarkable intracranial process going on, makes me wonder whether this could be like part of the, sometimes you can have EKG changes secondary to intracranial catastrophe. But that I would more think about like a Wallens pattern, in which you will see like diffuse seaway inversions in anterior leads. But this is more, the T inversions here are more remarkable and diffuse than what I would expect for just a Wallens syndrome. So yeah, I am worried about a cardiac process, and I'm trying to reconcile like a intracranial and a cardiac process. I remember like because in press you can have concomitant like a Takotsubo syndrome, a similar like where you have the vasospasm kind of picture. So like you can have I'm trying to, sometimes I confuse between like press and RCVS, but I think that might be more like RCVS, like in RCVS, you can have Takotsubo syndrome. So that is like reversible cerebral vasoconstriction syndrome. But that usually patient would present with like a thunderclap headache. And then you can have multiple like vasoconstriction on imaging. And then you could also have Takotsubo cardiomyopathy that is also part of the vasospasm. But then the thought of press came to mind because the imaging mentioning about the swelling in the occipital lobe. I have to there may be a knowledge gap for me. I have to read more about that, whether that is associated with Takotsubo or not. So that is one thought. So I think from here we have to work up both sides, both like cardiac, like getting troponins and serial EKGs, troponins, echo, and also get more clarity about the brain finding, like maybe an MRI. But I think another thought that came to mind is the convexo bleeding, because every time I think about like convexo, I know like for convexo subarachnoid hemorrhage is like a pretty unique finding, which is different from the classic subarachnoid hemorrhage in the cisterns. Like convexo, like there's really like a limited DDX with that. But if it's I'm trying to clarify more. So is it convexo I'm trying to look at this case aliquots. Is it like convexo subarachnoid hemorrhage, or is it convexo? Looks like it's more subdural hematoma. So maybe that is yeah. So yeah, there's actually a subarachnoid hemorrhage. So that is actually something I'm gonna like pull up my schema for convexo subarachnoid hemorrhage, which I think for that the differential would have so that is like different from like SAH around the cisterns, which is like typical for like aneurysmal SAH. So I think that the differential for a convexo bleeding would be I have to like kind of marinate around that a little bit, trying to remember what I read in the past. I don't see this very often. I think again RCVS or cerebral or CVST like cerebral venous sinus like thrombosis are all on the differential, even though we don't get like a history of headache from there. I think for CVS you would have more like a buildup of headache before a catastrophe happens. But again, we don't have the history because the patient couldn't really tell us. I think that could be a thing here. So yeah, I'm rambling a lot, but curious to see if Ravi, if any, could help me wrap up.
Oh, my friend, you didn't marinate the chicken. You burnt the chicken. You kind of went to town on this. So, superior recognition of potential factors in this case, which is interesting. So first with the EKG, I think, yeah, there's now some talk of PE. The chat has been talking, and if you break this down, and then the EKG can be very helpful. I'm kind of using my experiential learning, what I've learned from cases. EKG could be very powerful if it has certain features. And like you rightly mentioned, PE could have manifestation in the EKG, especially say you have new right axis deviation, which I don't see here, new right bundle branch block, S1Q3T3. And then you have this subendocardial or T-wave inversions, which you could see. But in this, I really like this, what you're talking about. Yeah, there is the brain-heart association. So yeah, Takotsubo is one, but intracranial hypertension or intracranial bleeding can also cause a sort of a neurohumeral surge on the heart and cause subendocardial ischemia. Hence, you get ST depression. You may get QT prolongation. You may get Osborne waves or these different manifestations. So here we are seeing these ST depressions. So I'm wondering, is it an intracranial heart issue, or is this a heart issue causing an intracranial? Yes, the bleed is secondary to the fall, but is the heart causing the fall? We don't know, but we're going to have to sort of run both scenarios to get to the diagnosis. But very good thoughts here. Now, the PE in practicing, Amory probably could also talk about this because yeah, as hospitalists, you see this and you have to think about PE. It has its own sort of a bucket. And if you go back to 2016, there was an article in NEGM and they found an association in some Italian study or a place that actually a good number of patients that showed up to the emergency room had PE as a cause of syncope. So their article was a warning sign. Think about PE in such patients. And they won't always come with the same scenario of chest pain, shortness of breath. They'll just syncopize without even knowing it. And then there was a follow-up study in JAMA, which showed that there was an association, but not as high as they mentioned. I think it was 60% in NAGM. So it's probably less, but still it's something it warranted enough of consideration when working up or generating a differential diagnosis for such a presentation. So PE is interesting. There's a lot of this intracranial thing that's going on. Is this signal or is this noise? But I think we got to kind of put our hands and feet on everything, sort of playing that game Twister, having everything all over the place, and giving equal priority to everything here. But there's nothing that maybe this EKG is something to latch on to, and then just following the breadcrumbs, getting an EKG, like you said, get an echo, do POCUS at the bedside. If there's new cardiomyopathy, that could indicate a endocardial or myocardial issue. But I'll send it back to Masa for the next aliquot.
I'll just add that, even though I rambled so much about like all the differentials for the like intracranial hemorrhage, convexo bleeding, I think in the end, to bring myself back to reality, I think it's most likely due to the trauma. Because the differential I mentioned were more, it was more for like spontaneous bleeding, and the differential can be like very interesting. But I think bring back to reality and to the base rate, I think those are likely due to trauma. And then so in the end it comes back to why did the patient had a fall and loss of consciousness, and I think that for that we can anchor on like the EKG abnormalities and the acute cardiac process. So yeah. Let's see what happens. Thank you, Masa. Please take it over.
Okay, that was awesome. So the next aliquot, we have a trope I, which was 40, and the normal is less than 20. And 2 hours later we got the second one, which was 250. And then over the next 14 hours, we had 2 additional ones, and the troponin was rising to 956 and then 2,496. His HbA1c was 8.3. His total cholesterol was 229. His LDL was 161. TSH was normal. And on TTE, he had an ejection fraction of 65 to 69% with inferolateral wall hypokinesis, but we didn't have a previous echo to compare it to. And I'll stop here.
Mengyu, you want to tackle?
Sure. Yeah, I
first?
forgot who's up next. Yeah. I think the troponin is very helpful here, and the degree of elevation I think is really direct us to think about coronary, like ACS, coronary artery disease, MI, especially supported by the echo with in wall motion abnormalities. I think the management here is tricky because you would normally want to start heparin drip and go to cath lab and like do antiplatelets and all that, but here with the intracranial bleeding, I think it becomes very, very tricky. I think this hugely here we involve neurology and cardiology to have a discussion, but like which is more significant. But I think regardless, the patient would really need perhaps would have to stabilize the neural bleeding first, but then would really need a left heart cath in the end to clarify, the degree of stenosis in like which coronary artery. Again, likely a proximal. I was also reading like inferolateral hypokinesis could also cause, like inferolateral ischemia could also cause like what appears to be like a more diffuse ST elevation AVR and diffuse ST depression. So yeah, what do you think, Ravi?
I think, what you mentioned is definitely gold. And if you put everything together, the pre-test probability of a primary cardiac process is building here. Now, there is an interest, like first, Mas had mentioned, first troponin was negative. I was like, okay, great. There's nothing in the heart. but you have to follow up. It may take time for the enzymes to be expressed in the blood because we're not sampling them direct at the source of the myocardium. Here, because they're ramping up, this makes more sense, that this is probably an issue of, we have on CPS the troponin pyramid. No, I'm not doing the Illuminati sign or whatever, but the troponin pyramid, which is very interesting if you're trying to decipher, okay, what do these troponins mean? Is it an issue at the base they have a supply issue? Then there's an increased demand issue, and then there's other causes where it could be due to like impaired filtering due to end-stage renal and so on. You had mentioned earlier on Takotsubo, which could be a cause too, that can cause elevated. That's in the other category. And the pattern usually for like end-stage renal or something that is Takotsubo is more this flat. Cardiologists tend to cause this, tend to mention it being flat and not rising this quick up and quick down, which would be a type 1 MI, or could be myocardial injury of non-obstructive coronary artery etiology, otherwise known as MINOCA. So yeah, right now I think, yeah, because of the previous history of coronary artery disease, and we also talked about all these factors and diabetes and silent MIs and so on, we definitely, and then the echo showing possibly hibernating myocardium. So there's a part of the heart which has regional wall motion abnormality. This could be the area of injury. So it's very important to think about, is this something that we need to rush the patient to cardiac cath? So if we classify this, we didn't see ST elevations, but the patient has risk factors, the pretest probability is high. And who goes, if they're a type 2 MI, or sorry, an NSTEMI, who goes to cath immediately if they have chest pain that's not resolved, troponins keep going up, if they have hemodynamic instability, if they develop cardiogenic shock, those patients need to go to cath lab ASAP. So I wonder, in this patient's management, did they think about sending this patient for an urgent cath to decipher what's going on? And it seems like there is a part of the heart which is lacking perfusion and is not showing appropriate motility. Back to you, Masa.
Ravi, I'll just add, I'm just regarding the information. I was like thinking another cause of ST elevation in VR, which I didn't emphasize or mention earlier, is like infarction of the basal septum, which is like basically a STEMI involving the AVR, which then cause reciprocal ST depression and other leads. Because the degree of, if it's like a really a proximal or severe disease, I would expect like more severe, more decrease in the LV function. But here it's pretty normal, and it's just the inferolateral wall. So which makes me wonder if it's just more the small portion involving the basal septum that was infarcted. But yeah, I'm curious to see.
Yeah, that's a good thought. Just sort of this bidirectional flow that we have, just sort of feeding off what you had mentioned, and that's a great fact. The area which is injured, when you look at these EKGs with ST depressions, V1, V2, V3, if you rotate the EKG upside down, it looks like an ST elevation. So that could be a posterior MI, which could be due to the right side. It depends on the I guess the major supply for this patient. So it could be a right coronary artery issue. But the AVR elevation, you're right, could be indication of multivessel disease. So I would, in fact, anticipate more diffuse or more global decrease in the ejection fraction. Over to you, Masa.
Okay, so this is our final aliquot, and then I'm gonna reveal the diagnosis later. So as you guys mentioned, cardiology and neurosurgery were involved, and he was started on heparin, drip, and aspirin with a plan for catheterization. However, upon serial CT head imaging, he had expansion of his subdural hematoma, and his heparin drip was discontinued. His troponin began to downtrend on the next check to 1,819. Later during the admission, a nuclear stress test was performed and revealed a large-sized territory of fixed defect involving the basal to mid-antero and anterolateral wall segments, and a large-sized reversible defect in mid to basal inferolateral wall segments. and I'll stop here.
So again, the way you're presenting it is so interesting. Fixed defect. I'm like, great. So in nuclear studies, and it was very interesting, because the patient was having worsening of their bleed, we couldn't put them on heparin. And during a cardiac cath, you have to put them on heparin as well. And especially what if you have to put a stent in? You stent, you'll need dual antiplatelet agents. Hence, that would also aggravate the bleeding. So another intervention you could do is to send the patient for a nuclear myocardial perfusion scan. And in that, you want to look for if there's any reversible defects, which would indicate that there's an area in jeopardy and there could be a vessel that's having blockage. And hence, that would give you a concern to immediately do some intervention at that point. So it looks like there is a vessel that, and where was this? It was a large size, and where was it exactly again, Masa?
The fixed one or the reversible one?
Reversible one.
Basal inferior lateral wall
Okay.
segment.
So that's where the echo also registered the abnormality. So, yep, definitely, I think cardiology would consider cardiac cath at that point. Any thoughts, Mengyu? But substantial in test that actually has implications on this case for us.
Yeah, such a dilemma in management. I'm curious to learn to see what actually happened. And I think I see someone mention in the chat about like maybe would need neurosurgery support by putting monitoring the intracranial pressure and putting a drain if needed, in case there's more bleeding. I think those are all definitely need like a tertiary care. But yeah, I'm curious what decision were made for the patient.
Okay, so upon subsequent risk and benefit discussions between the patient and all the teams, it was felt safest to defer catheterization until following discharge to reduce the risk of heparinization following his subdural and subarachnoid hematomas. And cardiology and the primary team ultimately felt like with his troponin trend, his focal wall motion abnormalities, and the stress test findings, the patient had either a type 1 MI with acute plaque rupture, either spontaneous or because of or triggered by seizure with spontaneous reperfusion, or a type 2 MI likely due to vasospasm, also triggered by the seizure. They were thinking more on the type 1 side because of the significantly elevated trope levels, because otherwise in a neurogenic stunned myocardium, which is the occurrence of cardiac abnormalities due to neurologic events, whether a seizure or stroke or subarachnoid hemorrhage, will usually have lower trope I levels. Patients will lack pre-existing cardiac disease, and there will be recent onset of cardiac dysfunction with a low ejection fraction, and they will usually also have wall motion abnormalities that do not match on EKG changes. So it's looking more like a type 1, but they couldn't like point exactly to which because they couldn't do a catheterization.
Well,
Oh wow, awesome. Like that's amazing. Could you elaborate? Did you say the findings, they think the specialists think the findings match the EKGs, right? Or no? I missed that part.
Yeah, in this case.
Okay, yeah, so that fits the type 1. Yeah, I think that makes sense because I was wondering like the sequence of events is like they think the patient had a seizure first and then had a triggered a MI and then had a fall and had all the bleeding. But that would be the type 2 theory. But the type 1 theory with the patient had a MI first and that triggered the fall and then a bleeding and then maybe seizure from the bleeding or something like that. Right. Yeah. I think even patient haven't had seizure for a long time, and now with the acute event seems to fit more with the type 1 theory. So I kind of agree with you. But a very interesting, complicated case. Thank you, Masa. What do you think, Ravi?
I think Masa just gave a superior explanation. The pattern to explain type 1 was extremely impressive. The echo, the EKG, the troponin, you gave a wonderful description of why you think it's type 1 versus type 2, and that pretty much answers the question. But I think this case just signifies how important it is to do simultaneous workup of all the different things that were mentioned initially. And what you had mentioned is specifically, I really love that you put everything together and made a argument for a type 1 because of the evidence that was given. So was there a culprit vessel, you think? I guess the inferior wall, maybe the right coronary was thought, but it'll be good to see if the patient gets what they find on a cath eventually when they do that. But for those that are listening, you're wondering, okay, how can you let a patient like this go home without any stent if they're thinking it's a type 1 acute plaque rupture? But there's certain things you can do. You can actually put the patient on a beta blocker. You can put them on high intensity statin. We would have to avoid the aspirin, obviously, because of the intracranial bleed, but at least lower the myocardial oxygen demand, and that way the heart doesn't have to work hard. Decrease afterload, maybe put on a ACE-ARB, get that blood pressure down. And the heart rate was 81, so get them to a target of 60 to 70, and that at least would help in the recovery of this patient. And give them also recommendations if they have recurring chest pain or any other indications to immediately come back to the emergency room to seek medical attention.
That's such great thought, Ravi, in terms of the medical management, even though we cannot do the typical, dual antiplatelet and stents. But I think the patients having EF normal, I think also makes sense, make the final decision make sense here. Maybe he would have, even though he's at high risk of reinfarcting, having another large MI. But I think considering the benefits, risk and benefits, I think that might be the best decision here. So yeah, thank you, Masa, for such expert presentation and also sharing such a dilemma and very, very interesting case. And thank you, Alec, for supporting this.
Thank you guys for this amazing discussion. I just want to say, if we were thinking of the type 2 hypothesis, we don't have a point of care glucose, but considering the patient took his glargine the night before, hypoglycemia could also have triggered the seizure, and seizure can cause MI in multiple ways. Seizure can cause autonomic dysregulation and excessive sympathetic activation, tachycardia, and hypertension, which increases myocardial oxygen demand, and that can cause ischemia. And then the seizure can also cause a coronary vasospasm, which would either mimic an MI or it would precipitate an already existing rupture, plaque, rupture. And then also seizures can also cause catecholamine surge, which in itself can cause a stress-induced cardiomyopathy similar to Takotsubo, and subsequently mimic or precipitate an MI, or it can cause the vasospasm and then mimic or precipitate an MI. And this is similar to a syndrome called Kunis syndrome, which is where ACS can be triggered by hypersensitivity or an anaphylactic reaction, causing vasospasm and then an MI. But here it's because of the catecholamine surge. And then one other way that seizure can cause an MI is by hypercoagulability. So seizure can transiently increase platelet aggregation and coagulation factors, and that increases the risk of thromboembolic events. And yeah, so just wanted to touch on the both types and the both hypotheses. But thank you guys so much for the amazing discussion and the teachings. And Sosan, I'm so excited for your EKG teachings. I'm really glad you captured all of these. But yeah, thank you.
Awesome, please take it over.
Okay, such a wonderful presentation, Masa, and a very rich discussion, Dr. Ravi and Dr. Mengyu, so thank you very much. So we started the case with an 81-year-old male who presents with a fall. So we're gonna approach this as history and physical examination. So a fall, is it due at an external cause or an internal cause? And then we started talking about causes of transit, loss of consciousness. And Dr. Mengyu gave us the 6S mnemonic, which are like sugar, seizure, stroke, syncope, substance, and also keep in mind environment and sleep problems. And then we were trying to differentiate between a syncope and a seizure. So a syncope is a momentary lapse of circulatory perfusion to the brain. And one way to differentiate between these two is to ask about the post-ictal state. And always whenever we're approaching any problem like in a patient and trying to find or figure out what's happening, always take a look at the past medical history, medication, assess for risk factors. For example, this patient had diabetes, could he have like a silent MI from the complications, coronary artery disease, causing the syncope to happen. Also investigate and ask about the social history, alcohol use, which can cause cognitive decline and eventually lead to like falls and trauma as well. And then moving to the physical examination and the findings that can help us. One thing to keep in mind is sometimes you can find elevated blood pressure in such situations due to stress and pain. And we have to trend the blood pressure if we're concerned for anything else. And other clues in the physical exam could be, for example, finding that pattern of bradycardia, irregular respiration, and elevated blood pressure in cases of can hint us toward an intracranial process and increased intracranial pressure. And always, whenever we have a patient with syncope, we have to assess for orthostatic vital signs. And then moving to the labs and imaging, we started with the ECG. So the patient had an ST elevation in AVR, and with that, we learned from Dr. Mengyu that this has a narrow differential diagnosis. For example, are we having a diffuse stenosis in proximal left anterior descending artery, or like having a multivessel disease, or are we having an acute PE and hypoxia that is causing that? And always keep in mind the patient's presentation and take it into consideration when interpreting an ECG, as intracranial process can give us secondary ECG changes, and which is known as the Wellens pattern. This leads to like inverted or biphasic T waves in the anterior leads. And also keep in mind any condition that could cause a catecholamine surge can lead to subendocardial ischemia and give us the presentation of ST depression, QT prolongation, and Osborne waves, as we can see in Takotsubo myopathy. And then for the troponins, we always have to trend them. Or do we have a flat pattern, uptrending, downtrending? And also keep in mind that it can be, the troponins can be negative early on. And then I learned a new thing about the nuclear study interpretation. If we have a reversible finding, this could mean that we have a blockage in a vessel at jeopardy right now, and this requires an emergent intervention, that it is something like acute. Rather, like if we have a fixed finding, this indicates that we have an old and like a dead myocardium. And then Masa taught us about how can seizure and MI be related. Seizure can cause MI through like autonomic dysregulation, a catecholamine surge, coronary vasospasm, and she also taught us about something called Connors syndrome, where we have ACS that can happen in cases of anaphylactic shock. And thank you very much.
Wow, that's amazing, Salsa. Thank you so much for capturing all the great teaching points in such an organized way. I'm so impressed. Yeah, I hope everyone have a good day. And thank you again for scribing Menahil. And have a great day. We'll see you next time.
Take care. Thank you, Mengyu. Bye.
Bye.